Yeah, we're live on YouTube. Dr. Sridhar, over to you.
Yeah. I'm Dr. Anil Sridhar, Secretary of the PATS 2025, and I welcome Dr. Sungoj Bhaskar Sir, President PATS 2025, and my team of EB, and also my treasurer RSP Krishna, to this PATS webinar 2 webinar series, which is started by as a presidential plan, action plan by Sungoj Bhaskar Sir. And I welcome Anil Jalan Sir for this second webinar, which is going to start now within 1 minute, sir, and will not take much time. You know very well how much the doctors are showing interest in this web series. Yesterday also, this webinar, so many doctors had called me. You on the national level, do send the webinar link, this link of the webinar. So I have sent them to them. And I think YouTubers also were very much interested to see the recorded passion. And really, the first webinar was huge success with having more than 750 to 800 YouTube viewers. And coming to this second webinar, which is more interesting than first webinar, the normal structure of the gene and also definition and types of genetic variations and genotype and phenotype correlation. These are all the things. Before starting, I want to request my President Sungoj Bhaskar Sir to start the webinar. Sir, please, sir.
Namaskar. Good morning all, and welcome you all to this second episode of our webinar series on medical genetics. And this is one of my favorite presidential action plans for 2025. The reason being, we had realized the importance of genetics in our day-to-day practice, in our clinical practice as well. So then I requested Dr. Prajna Ranganath. She was kind enough to prepare the entire program for 12 months, well in advance 6 months ago. So, especially I welcome the faculty members, Dr. Ratnapuri Madam from New Delhi. She's a professor of genetics and chairperson, Institute of Medical Genetics and Genomics at Sir Gangaram Hospital, New Delhi. Our Dr. Prajna Ranganath, I proudly say our Prajna Ranganath, to be the convener of this entire series. She's a backbone for this. We really appreciate her commitment or passion for the academics. And our special invitee today is, as you all know, Dr. Prajna Ranganath is a professor of medical genetics at prestigious Nizam's Institute of Medical Sciences, Hyderabad. And thank you, ma'am. And our special invitee, Dr. Anil Jala. Sir, I'm thankful to you at the short notice, despite your travel, so you're supposed to move to airport right now. Despite that, you had accepted to grace this occasion. As you all know, Dr. Anil Jalan is a pediatric geneticist, very much interested in metabolic disorders of children. Thank you, sir, once again, and hopefully we will have you in our future academic program. And as our Secretary General, Dr. Sridhar said, a lot of people even called me and agreed with me and appreciated me for having this program on genetics, because most of the clinicians are interested, but they don't have this kind of continuity of medical education program. So they had appreciated us. And also, as Dr. Sridhar said, there's a good viewership on YouTube. I'm sure it's going to be a big success. And this there's a request for recap of the earlier episodes. So then I requested our Dr. Prajna Ranganath to have a recap of at every session of the earlier episode. That would fresh up our memory and we'll have continuity. So with this all, I don't want to speak much, which is a non-academic thing. So wishing you all a great learning experience. Once again, thank you all. And I thank all the participants and my executive board team, which is so kind enough to support me in all these academic activities. Thank you, and Jai IAP and Jai.
Thank you, sir. Thank you, sir. Before starting the webinar series, I request our today's guest, Dr. Anil Jalan, sir, to say a few words. Sir, unmute yourself and say a few words, sir. Anil Jalan, sir, please.
Good morning, everyone. Can you all hear me?
Yes, sir.
Okay, good morning. and thanks a lot for invitation. Unfortunately, when Dr. Bhaskar called me, I had already made my plan and I had to go to airport by 10 o'clock. So anyway, this topic is really very interesting for clinicians. And sometimes I'm now talking about clinicians and our approach to genetics. There is a lot to learn. Every day there is some new development, both in clinical side as well as the laboratory side. So it becomes difficult for a clinician to keep abreast with everything. And these kind of webinars definitely help. I'll just give one example and try to elaborate few points within next 2 minutes. So just 2 days ago, one family came with a child who was about now 4.5 months. And in the newborn screening, it was shown that child has high galactose. So when it was high, they had sent a sample and asked for the GALT enzyme, and we did GALT enzyme, which was normal. But we suggested it may be some other form of galactosemia. And genetics should be done because other enzymes are not easily available. So they went ahead with the genetics part, but it took 2 months to get the results. Until then, child was on milk, and they continued really high doses of milk. They had supplemented from outside also. And then they came to us with the result saying this is galactokinase deficiency. Of course, we have to stop galactose and everything. So then when I took the history, and this family has a lot of problems, both grandfathers from both sides, mother and father side, they have some kind of malignancy. Sister of this child has congenital adrenal hyperplasia. One of the cousin has spondyloepiphyseal dysplasia. And this particular community is prone to have there is a high incidence of thalassemia and even sickle cell disease. And none of this was addressed during genetic test. I'm not blaming genetic lab because they were not given any information about this thing. And probably the primary physician or pediatrician or a neonatologist who was too busy to take any history, and everything was missed. Now, this is where now the family gets upset. Now, family goes to some international experts. Fortunately, that international expert was my teacher. So they referred back, and then we could calm them down. Now, some families may go to court or all those things. So the point here is it's a duty and a responsibility of the primary physician to take a detailed history. I'm sure Dr. Prajna must have spoke about or will be talking about taking detailed history, drawing pedigrees, assessing the risk. The most important part is when you ask for a genetic test, give all the relevant information, not just high lactose or high galactose, whatever. So one phenotype may be enough for that particular child, but we need to have history and submit everything to the lab and ask for a comprehensive result. So this is what we all have to learn: how to take history, how to draw pedigree, how to understand the genetics part. And sometimes it so happens that we get a genetic result and we are surprised. Oh, it's not matching our clinical phenotype. Like I was suspecting phenylketonuria and it turned out something totally different. So in that case, what to do? So if we understand what test are we asking for, what is the phenotype, and sometimes we ask for a wrong test, or sometimes we get a result which does not match, then you need to consult your local genetics expert and see where and what has gone wrong before even talking to the family. So this is what I think in this kind of seminar or webinar, we all clinicians should be learning. So what are the pitfalls? What are the difficult areas for a clinician? Nobody can be expert in all the types of genetic diseases. Like I cannot handle routine genetics. I cannot handle all the muscular dystrophies and things like that. So you need to really find out somebody who can do that. And it is very essential in this kind of webinar to understand the basics. So that will really help us to progress further. And as a clinician, we need to do what we can do and then consult somebody like Dr. Ratna or Prajna or when I am there or anybody. So we need to chalk out all those things. So thank you very much for the invitation. And the essential part here is to learn the basics rather than the complex thing and not to get overwhelmed by the advancing technology and a lot of genetics. But if we have basics clear, we can do a lot. Thank you very much.
Yeah. Thank you, sir. Excellent message, sir. Learn the basics is a beautiful word. All the guides and teachers will be telling the same things where you are again started. So really, it is interesting, sir, your message and your case history. And I now request our Sri Krishna RSV to start the webinar and welcome Prajna madam and our Ratna madam. And Sri Krishna, Sri Krishna, Sri Krishna RSV.
Satish is there. See that. Satish is there.
Ah,
సార్ మీరు స్టార్ట్ చేయండి సార్ మీరే వెల్కమ్ చెప్పి స్టార్ట్
Sri Krishna.
Yeah.
సార్
You can
సార్
start.
లేనట్టున్నారు సార్
See that.
Sridhar,
Please start.
Yeah, please start.
Yeah. Madam, over to Dr. Rajna Ranganath, madam.
Thank you, sir. So, at the outset, I'd like to begin by thanking IAP, TCB, and PATS, and in particular, Dr. Sunkoch Bhaskar, sir, for this excellent initiative and this wonderful opportunity. As Dr. Anil Jalan, sir, rightly pointed out, you definitely, all clinicians, need to have a very sound knowledge of the basic concepts of genetics because genetic disorders, genetics plays a very important role in a lot of the disorders that you see in children, because a lot of them have pediatric onset. So today we are very fortunate to have amongst us Dr. Ratnapuri ma'am, who is one of the senior most geneticists in the country. And ma'am will be giving us an overall approach to monogenic disorders. But before ma'am begins, I will actually just take you through some of the basic concepts of genetics. And also, before I begin that, we'll do a quick recap of what we discussed in the previous session. So this is what we began with last month. So if you remember, overall, three main types of genetic disorders. Now, this is of course a rather simplified view, but for as clinicians, I think it would suffice for us to at least remember this much, that overall genetic disorders can be broadly classified as gross chromosomal anomalies, where you have numerical or structural abnormalities of chromosomes. Then you have the chromosomal microduplications or the copy number variations, which are actually small gains or losses of chromosomes, which are not big enough to be picked up in a conventional karyotype. Then we have the monogenic disorders, which are caused by mutations in individual genes. So there are nucleotide changes which cause the condition. And before we do any sort of genetic testing, it's extremely important to do a thorough phenotype delineation because unless and until we have a proper phenotype delineated, and unless and until we have a specific set of differentials in mind, we will not be able to choose the appropriate genetic test. Neither will we be able to accurately interpret the genetic test results. So a proper detailed history, as Dr. Anil Jalan rightly highlighted in his brief address, should always be taken for each and every family, for each and every patient. And this should include a history of the prenatal, perinatal, neonatal events, the developmental milestones, and of course, the history of the disorder per se. Then a detailed family history and a minimum 3-generation pedigree are absolutely essential. A thorough dysmorphology evaluation should be done. And of course, a detailed systemic examination. All the relevant lab investigations and imaging studies are important because even in this day and this age of all these complex advanced genomic testing technologies and all the other omic technologies which are available, basic phenotype and a proper pedigree are invaluable tools in helping you identify the condition and helping you make a diagnosis. Pedigree drawing, very important. Uh, just a free tool, but an extremely important tool for your genetic diagnosis. So, minimum 3-generation pedigree has to be drawn for every family with a suspected genetic disorder because it provides important clues regarding the pattern of inheritance and also helps identify at-risk family members who require carrier testing, pre-symptomatic testing, prenatal testing, and so on. And as Dr. Anil Jalan pointed out, sometimes you may have more than one genetic disorder in the same family, and you need to address that as well. You cannot just address the phenotype of only the proband. So this is again something which was discussed in the previous class, the indications for karyotyping. So briefly, when you have a clinical suspicion of a specific chromosomal disorder, one of the most typical examples being Down syndrome, that's when you would go for karyotyping. Also, any girl with unexplained short stature with or without Turner stigmata, any individual with a disorder of sex development, which could be ambiguous genitalia or hypogonadism, unexplained intellectual disability, global developmental delay, multiple malformation syndrome. Again, you can do karyotyping as the first line test, but the yield of karyotyping is pretty low in such cases. It, of course, couples with recurrent pregnancy losses. These are the tests you do for chromosomal anomalies. The basic routine cytogenetic test is, of course, karyotyping. And then when you want to look at the microdeletions and microduplications, for targeted microdeletion, microduplication studies, you will use either FISH or MLPA. And for a broad spectrum genome-wide coverage, you would go for chromosomal microarray. So this is the analogy which we had given last time also. Looking for gross chromosomal anomalies through karyotyping is like looking at the books on the shelf. Something is missing, something is extra. You'll be able to pick up just by looking at the books. But when you want to look for specific microdeletions, microduplications, you have to open the pages and look at that particular page where you know that deletion is likely to be. So that's like doing the targeted FISH or MLPA. And then when you want to look for torn pages across the book, so that's like looking for copy number variations or microdeletions, duplications across the genome, you would go for this genome-wide CNV study, that is chromosomal microarray. But when you're talking about monogenic disorders, you're actually talking about spelling mistakes. So you're talking about variations at the level of the nucleotide. And here, your cytogenetic, molecular cytogenetic techniques do not help you. You have to go for molecular genetic techniques. So these are the things which are caused by single nucleotide variants, small few base insertions, deletions, and so on. And this is the scale of genomic variation where you have 100 million bases, hundreds of millions of bases involved in chromosomal disorders. Whereas when we talk about single gene disorders, we're talking about individual nucleotides. So that was a quick recap of what we covered in the previous class. And now moving on to today's topic per se. So ma'am will be covering the approach to monogenic disorders in detail, including all illustrative clinical scenarios to highlight various points related to these single gene disorders. So I'll just be taking you through this basic terminology so that whatever ma'am will be talking about, I'll be just explaining what those terms refer to. So for this, for the purposes of understanding these basic terms, I have just taken one illustrative report. So this is what a report, a molecular genetic test report would normally look like. You will have all these terms mentioned there: gene, transcript, location, variant, zygosity, classification, and pattern of inheritance. So in this particular talk, I'll be just addressing what these basic terms mean. I'm not really going into the clinical scenarios here because that would be covered by Ratna ma'am. So the gene. Now the gene, of course, we all know what it refers to. It's a basic unit of heredity. Each gene is supposed to code for one polypeptide or one protein. And the proteins or the polypeptides in turn go on to carry out the various functions in the cell. So there are about 20,000 genes known in the nuclear genome and another 37 genes known in the mitochondrial genome. So how do we get information about all these genes? It's virtually impossible to remember each and every gene for each and every disorder. Several databases which help us with this. And one of the most commonly used databases, which is also fortunately open access free, is OMIM. That's the Online Mendelian Inheritance in Man database. You can simply type omim.org. It takes you to this site. And this will then be, so you can type in the name of the gene, the name of the disorder, and it will give you all the relevant information. So for example, here our gene is SKI. So that's what I type, and it takes me to this. And then when I click on this, it shows me the information about this gene and also the phenotype, which is known to be associated with this gene. Sometimes one gene, and not sometimes, in fact, many genes may be associated with more than one disorder. So it will list all of those. And then when you want to know in greater detail about each of these disorders, you click on the phenotype number, and then it takes you to the phenotype, the OMIM phenotype page, where you can get all the information in a very concise manner about the disorder. Next, what's a transcript? So a transcript is nothing but alternate gene transcripts are essentially different mRNA sequences which are synthesized from a single gene. So we know that a gene undergoes transcription to form the mRNA. So the gene may undergo transcription in more than one way, and as a result of that, you can get alternate gene transcripts. So every gene transcript is given a unique identifier called a transcript ID, and the position of the same variant can differ in different transcripts. For example, now this red thing here indicates a particular position on exon 3 of this gene. So in transcript 1, it is showing up in exon, it's showing up over here. Transcript 2 actually lacks exon 2. So the position of the variant will change there. In transcript 3, it is not even present because exon 3 is not included in that transcript. And transcript 4, again, it's in a different position. So although it's the same variant we are referring to, position is different because the transcript number, the transcript sequence is different. And therefore, the transcript ID should always be checked and mentioned when you're mentioning the position of the variant. Next, moving on to what we understand by the term variant. So previously, we used to use the term mutation. So mutation is the conventional term which is used to refer to a permanent alteration in the nucleotide sequence of the genome of an organism. But nowadays, the preferred terminology is genetic variant or genetic variation, which refers to any difference in the DNA sequence of an individual compared to the reference genome sequence. So the terms variant and mutation are often used interchangeably, but the present norm is to use the term variant. But of course, all variants are not disease causing. A variant is simply a difference in the DNA sequence. It could be benign also, it could be pathogenic also. For some variants, we do not yet understand the significance, and those are the ones which are called variants of uncertain significance. So quickly, what is a missense variant? A nucleotide is replaced by another, which results in substitution of one amino acid by another because of the change in the codon. So that's a missense variant. The nonsense variant, on the other hand, is where the nucleotide is substituted by another nucleotide, and the new codon is a stop codon. So the previous codon was supposed to code for a particular amino acid. The new codon which is created is a stop codon, and the translation stops there. There is no further continuation of the translation once the stop codon comes in, and therefore that's called a nonsense variant. Synonymous variants, on the other hand, are those where there is a substitution of one nucleotide by another nucleotide. There is a new codon created, but the new codon also codes for the same amino acid as the previous codon, and therefore there is no change in the sense, and that's why it's called a synonymous variant. Insertions with frame shift. So if you have one or more nucleotides which are inserted, which are not in multiples of 3, it changes the way the nucleotides are grouped together. In other words, it changes the codon pattern, and therefore downstream to the insertion, all the amino acids change. Similarly, if you have a deletion which is With the frame shift, that's to say, which is one or a few nucleotides not in multiple of 3, it will result in a frame shift. But if you have a deletion, which is in multiples of 3, for example, 3 nucleotides are deleted here, so only one codon goes missing. The rest of the codons are intact. So one amino acid goes missing in the sequence, but then the other amino acids are intact. There is no change in the reading frame. You can also have like small deletions are generally like this, where a few nucleotides are deleted. Small duplications also can happen where a few nucleotides are extra. But you can also have larger intragenic deletions and duplications where entire exon or more than one exon may go missing. So these are the different kinds of variants that you can have in the gene. Usually, nonsense variants and frameshift variants are pathogenic because they result in truncation of the protein or in creation of a protein which is a totally different amino acid sequence. Missense variants sometimes alter the protein function, sometimes do not alter the protein function. Accordingly, some of them are pathogenic, some of them are benign. Synonymous variants, because they do not change the protein sequence, are usually benign, but there are exceptions to this rule. Sometimes synonymous variants can alter the way the transcription happens and thereby alter the protein sequence and thereby cause disease. Moving on to the location of the variant. So we all know this is the basic structure of the gene. Of course, it's far more complex than this, but I've just simplified this for the purposes of better understanding. So exons are portions of the gene that code for the amino acids. Introns are the portions that do not code for the amino acids. And the splicing is the mechanism which happens after transcription, wherein the non-coding portions, the introns, are removed, and the coding portions, that is the exons, are joined together. So your mature mRNA consists of only exons, and this is what gets translated into the amino acids that form the sequence of the protein. And the site splicing happens are called splice junctions or the splice sites. These are the junctions of the exonic and the intronic sequences where the splicing happens. So generally, if you have a variant within the exon, it is more likely to be disease-causing because the exons are involved in the coding portions. The exons are the coding portions which code for the amino acids. Variants at splice sites, again, tend to be disease-causing because if there's a variation at the splice site, it will change the way the transcription is happening. Whereas deep intronic variants do not usually cause disease. They're typically benign because they do not contribute to the coding. But then sometimes even the deep intronic variants can alter splicing and thereby cause disease. Moving on to the zygosity. What do we mean by zygosity? So when all genes are present in 2 copies, so if except the ones on the sex chromosomes, that is in male individuals, because male individuals have 1X and 1Y. Other than that, all the autosomal genes have 2 copies. So between the 2 copies, if one copy of the gene has the variant, that's called the allele, that is said to be heterozygous. If both copies, both alleles of the gene have the same variant, it's called homozygous. If the 2 alleles, the 2 copies of the gene have 2 different variants, it's called compound heterozygous. And in male individuals who have only 1 copy of the X chromosome, if the gene is present on the X chromosome and the variant is present in that gene, it is said to be a hemizygous variant. So autosomal dominant disorders are caused by heterozygous variants. Autosomal recessive disorders, the affected individuals will be homozygous or compound heterozygous for the variants, whereas carriers will be heterozygous for the variants, the carrier siblings. X-linked disorders, the affected males will be hemizygous for the variant, and carrier females will be heterozygous for the variant. For X-linked dominant disorders, even heterozygous females will manifest the condition such as Rett syndrome. Moving on to the classification. Again, this is a very complex topic in itself, so I'm not going into the details, but these are the standards and guidelines used for classification of the variants. These are the ones given by the American College of Medical Genetics and Genomics and the Association for Molecular Pathology, as per which variants are classified as pathogenic, likely pathogenic, variants of uncertain significance, likely benign, and benign. And for pathogenic and likely pathogenic variants, there is sufficient evidence in the form of functional studies, previous reports, robust evidence in databases, which exists that the evidence exists that the variant is definitely causative for the disease phenotype. Likely pathogenic, you do have some evidence, but additional evidence is expected to completely confirm the pathogenicity. Of course, we don't need to go into the details right now of what are the parameters which are taken into consideration, but it would suffice to say here that generally, if you get a pathogenic or a likely pathogenic variant in a gene which is matching your clinical phenotype, and that variant you're getting the zygosity of the variant is as per what is expected for that disorder, plus the segregation pattern of that variant in the family is matching. That is to say, for a recessive disorder, you would expect the child to be compound heterozygous or homozygous for the variant, parents to be heterozygous for the variant. So if you get a clear pattern fitting into that, then you can take that variant to be the disease-causing variant. Benign, likely benign variants are generally not disease-causing, and variants of uncertain significance, right now you do not have sufficient evidence of their pathogenicity. With time, you may get more studies, reports from elsewhere, and that may help you reclassify many of them. And they may get reclassified subsequently as either likely pathogenic or likely benign, and so on. And finally, the pattern of inheritance. So we know primarily you have Mendelian and non-Mendelian inheritance patterns, but the basic three Mendelian patterns of inheritance are autosomal dominant, autosomal recessive, and X-linked recessive. X-linked again is called X-linked recessive, X-linked dominant, X-linked semi-dominant. So many things are there. But now we know that X-linked disorders have a spectrum of manifestations in female individuals, and therefore they are referred to as just X-linked rather than X-linked recessive or X-linked dominant. So quickly, in autosomal dominant inheritance, we know that the transmission can happen to offspring of either sex. The risk of recurrence in the siblings of an affected child would be 50% if the parent is affected. And if neither of the parents is affected, it may be a de novo variant in the proband. But because of the possibility of gonadal mosaicism in one of the parents, the empiric risk of recurrence is generally given as 1%, where the mutation can be present in a proportion of the gonadal cells, one of the parents that will not show up in the blood DNA. Autosomal recessive inheritance, both parents are usually carriers, heterozygous carriers, and the risk in each offspring of heterozygous carrier parents is 25%. And X-linked recessive inheritance, mostly the males are affected, females are usually normal carriers. If the mother is a carrier, there is a 50% chance of each male child being affected. But again, I also told you, you also have X-linked dominant conditions and so on in female individuals like Rett syndrome. So overall, these are now called X-linked disorders. So for further details, you can. So we have this very good gene top course on the website of our Indian Academy of Medical Genetics. You can register for this course, and we have a lot of lectures on the basic concepts of genetics and also various different aspects of clinical genetics of use for clinicians. So I'll stop with that. And I now invite, so we'll take the questions at the end of both the talks. So we'll please address your, please type in your chat box, and we can take them up after Dr. Ratna ma'am's talk is over. So now it's my proud privilege and pleasure invite Dr. Ratna Duapuri ma'am. She is professor in genetics and the chairperson of the Institute of Medical Genetics and Genomics at Sir Gangaram Hospital, New Delhi. Madam completed her MD in pediatrics from the prestigious AFMC Pune, followed by she did her DM in medical genetics at SGPGI Lucknow. So Madam is my senior from Lucknow. She is the current president of the Society for Indian Academy of Medical Genetics. She has been the recipient of several accolades and awards, and including the Dr. I.C. Verma Outstanding Researcher Award for the year 2019, the Dharamveera Award of Excellence for the year 2010, and the Young Investigators Award in Tokyo in 2006. She's a member of several prestigious groups, including the Diagnostic Scientific Committee of the International Rare Diseases Research Consortium, the Undiagnosed Disease Network, of NIH USA. She's also a member of several government level important committees, including the National Consortium for the Research and Development for Therapeutics for Rare Diseases in India, and also a member of the Technical Expert Committee on Human Genetics, Genomic Engineering, and Nanotechnology. She has more than 160 publications to her credit, and her research interests include the Indian Undiagnosed Diseases Program, the use of artificial intelligence in genomic profiling and the diagnostic yield of the same, and also familial hypercholesterolemia. Madam, we are very privileged to have you here today. Thank you so much for sparing your time and sharing your expertise and knowledge with us. Over to you, ma'am.
Thank you so much, Pragnya, for that very, very kind introduction. And at the outset, I would really thank IAP Telangana for this mammoth effort, as well as Pragnya for taking the lead in doing something I think which is really the need of the hour. So without wasting any more, oh my God. Hello? Can you see my slides?
Yes, ma'am.
Yes, ma'am.
Okay.
Able to see.
So Pragnya has given a very apt introduction to what I was asked to discuss today, and that was decoding monogenic disorders. It's a case-based series so that I feel with cases, everybody is able to emote with case scenarios and recollect what the situation demands. So beginning from the very basic, mono and genic. So mono means single and genic means gene. And we've already gone through this, so I'm not going to repeat it. But what we're going to discuss today are single gene disorders that are caused by changes or variants in a specific gene. Mostly they follow patterns of Mendelian inheritance, but we know that in science 2 plus 2 never makes 4. And therefore, as technology enhances and our information and knowledge about genetic diseases improves, we understand that there are many disorders which don't follow these patterns of inheritance. And these are disorders that are caused by single genes, variations in single genes. And that is referred to as the non-Mendelian pattern of inheritance. So there's a whole armamentarium of molecular genetic techniques, and the test that we use will obviously depend upon the nature of the disease gene that is being studied. So there are these, various technologies that I've put down, which we've been using in different situations. We can hybridize, that means link two complementary parts of the genes together. We can cut a gene to try and identify a change in a gene. We can do a modification of a PCR to understand what is the gene mutation. We can look at various deletions and duplications in the gene by MLPA. We can sequence every alphabet in the gene, ATGC, by Sanger sequencing. We can look at large repeats, expansions by a specific TP-PCR. And now what we all know, and a lot of us use, is next generation techniques of exome, clinical exome, or genome, essentially to confirm a diagnosis in a patient. But as from the start of this webinar with Dr. Jalan, I think the one thing that stands out, and then followed by what Pragnya said, the most important thing is a family history and a clinical examination. And without that, we cannot decide what test we want. And therefore, every case will have to start by the bedside, like we learned in MBBS and in MD, that you start by looking at the patient, taking the details, summarizing the details as I have here, where we have a child with short stature, no other affected member in the family. He has a typical trident hand, a relatively large head and a small thorax, and cognitively the child is normal. And because the child has disproportionate short stature, we would like to take an X-ray. And when we take an X-ray, we would, what we say a skeletal survey, because it's a small child, everything comes up in one X-ray. And seeing the details in the spine, the tubular bones, and the pelvis, we make a diagnosis of achondroplasia. Then we go on to understand in our background knowledge that we know that achondroplasia occurs because of a mutation in a gene. It is autosomal dominant inheritance. But I think the most important thing that we have to go back and check, and you can do this in the reference that Dr. Pragnya gave in OMIM or in gene reviews, that more than 99% of patients have one of these two mutations in the FGFR gene. So FGFR gene is the gene that is responsible for achondroplasia. And if we have this substitution or a missense variant, 1138G to A or 1138G to C, we need to look for these two mutations to confirm the diagnosis. Now, 80% of cases are like this, the first occurring case in the family. However, we also know that at times, if both parents are normal, we can still have two affected individuals, and this is referred to as gonadal mosaicism. The incidence is small, it's less than about 1%. So therefore, if you have one affected child, it's very important to offer prenatal diagnosis in the next pregnancy for the small chance of gonadal mosaicism. In achondroplasia, we can also have a situation where one parent is affected. In that case, the risk of disease to every sibling is 50%, and there's a 50% chance that offspring. And there's a 50% chance that the offspring would not be affected. So it's very, very important that we confirm the diagnosis because there are many mimics of achondroplasia. And today there are also specific therapies like voseritide for achondroplasia. And to even think of being able to offer prenatal diagnosis or treatment, we need a specific diagnosis. Now, how do we do it? Because we know that there is one of two mutations in more than 99% of the cases. We can use simple techniques of either RFLP or Sanger sequencing. If you make a clinical diagnosis, this is not a situation where you need to do large expensive tests like next generation sequencing. So these sort of gene-based tests are very specific for the disease that is being tested. And if you have a very close differential, that will not be identified. For example, hypochondroplasia. Hypochondroplasia is a mimic of achondroplasia, but it's much milder than achondroplasia. We know that hypochondroplasia also occurs because of mutations in the FGFR gene. However, the mutation is different. In hypochondroplasia, the mutation is at the position 1620 and a change from C to A or a change from C to G. With this background knowledge, we can order Sanger sequencing or targeted testing for hypochondroplasia mutations. The method that we use would be Sanger sequencing. So here you can see that this is the change C to A. The C is blue and the A is green, or C to G. The C is blue and the black curve is the G curve. Now we come to case 3. This is a 3-year-old male resident of Jharkhand. He presented with pallor, icterus, history of abdominal pain and joint pains. He was noted to have mild splenomegaly. There were 2 previous hospital admissions for pneumonia, fever, anemia, and jaundice. He received 3 transfusions ever since he became symptomatic. There is also a history of previous SIB death, which was really never evaluated in detail for fever and jaundice. Now, this specific child had anemia and leukocytosis. So like any pediatrician, we would all go forward and evaluate the anemia. But as a geneticist, I know that there is a previous affected child, and also he hails from Jharkhand. And we then know that when we look at the peripheral smear, we see sickle cells, we see other features of hemolysis, and the sickling test is positive. The HPLC, hemoglobin A2, done on the BioRad variant 2 machine shows that the child is hemoglobin SS disease because that's the predominant hemoglobin that he has, and the father and the mother are heterozygous carriers for hemoglobin S. So they have some A and some S. Now, we know that this is an autosomal recessive disorder. Both copies of the gene have to be affected for disease. For any autosomal recessive disorder, it could be homozygous or compound heterozygous, and this has already been alluded to. Now, it is well known that sickle cell anemia is a monogenic disorder. It's autosomal recessive. Either we diagnose the parents because of an affected child, or they could be diagnosed incidentally when a hemoglobin or an HPLC A2 is done. And we know that they come from the central part of India where sickle cell disease is common, or where we do family studies. A niece or a nephew or a relative is affected with sickle cell anemia. We know that in that family, there could be sickle cell anemia carriers, and therefore the HPLC hemoglobin A2 test is done. Now, sickle cell disease is an example of one disease and one mutation. So here, again, targeted mutation testing is done after a clinical diagnosis is made. The one mutation, this is the hemoglobin gene. It has 3 exons, exon 1, 2, and 3. And you can see that the sickle cell mutation is this. This is the one mutation, C.20 A to T. At the protein level, it is change of glutamine to valine at the codon position 6. So therefore, the test that is done for sickle cell anemia is this targeted test. We do it by Sanger sequencing. We can use any other method that the laboratory has set up, but the test to be ordered is the mutation testing for sickle cell anemia. The patient, our patient, is hemoglobin SS and is homozygous for this specific sickle cell change. Sickle cell could also occur because of a combination of hemoglobin S with any beta thalassemia variant. It could also occur because of a combination or a compound heterozygosity with hemoglobin S and hemoglobin C disease, or hemoglobin S and hemoglobin D disease, or hemoglobin S and hemoglobin E disease. And each of these, D, E, and C, again has specific gene changes, just like hemoglobin S. So, therefore, once we know what we need to test for, you do targeted molecular testing for that specific disease gene. On the other hand, we come to the second part of these hemolytic anemias, which is thalassemia major, which we all know is the commonest autosomal recessive disorder in India. We should suspect in every child with anemia and hepatosplenomegaly because it's important for treatment and counseling for recurrence. The mutation has to start with the affected child if there is a positive family history. All affected members of one family will have the same mutation, and this is what I'm going to show you. Now, this is a typical scenario. Here, there is no affected child. The parents were tested as all pregnant ladies are tested for the beta thalassemia carrier state, and that is actually a mandate as per the recommendations by the government for beta thalassemia and other hemoglobinopathies. Now here we can see that both partners have microcytic hypochromic anemia. The RBC count is a little higher, and therefore there is no doubt that here for the wife, the A2 is elevated and she's a beta thal carrier. However, if you see this side of this table for the husband, he is a carrier of hemoglobin Q India, which is a variant in the alpha gene. But what is important to know, and actually the eye will see only if the mind knows, is whenever you have hemoglobin Q India, the MCV, MCHC, and the RBC parameters should be normal. When we suspect that there is microcytic hypochromic anemia, the RBC count is high for the level of hemoglobin, the A2 is borderline, we must test for beta thalassemia. This is one aspect of a mild silent variant where the A2 is not as significantly elevated as in the wife. And here you can see that when you sequence both partners for thalassemia mutation, so we sequence the HBB gene, a variant in the beta globin gene is identified in the husband, in the lady, and the father is also excuse me, is also a carrier for hemoglobin Q India, which is actually innocuous. And then based on this information, a prenatal diagnosis is done to evaluate whether the fetus in this pregnancy is affected or not affected. So this is the beta thalassemia gene, and unlike sickle cell disease, which has only one mutation, there can be multiple mutations in the gene or variations in the gene, as it's referred to now, that can cause disease. It is well mapped out in India, and we know that more than 90% of the patients have one of 5 mutations. And up to about 99% of the patients have one of 10 mutations. So that makes our job very easy. We know, and actually, if you can see in this graph, it's mapped out what is common in the north, south, east, west of India. It's a very, very well characterized disorder in our country, and therefore testing for mutations in beta globin gene should not be of any consequence for any laboratory. And the common method that is used for this is Sanger sequencing. Sometimes if we want to check for common mutations, we can also use the ARMS PCR or the dot plot method, but that is dependent upon the laboratory, their expertise, and what they are comfortable in using. Then I come to the other concept of targeted testing. Now, this proband here is known to have 2 mutations. See the one in the yellow and the one in the blue, one inherited from the mother and the other from the father. Both parents are carriers. Now here, there should be no second affected child. But now that there is, we know that this sibling will be a carrier of this variant. And therefore, you don't need to do a full Sanger sequencing. You can just check for this variant here. But if we test the child and we know, then we have to test the lady. By chance, she's also a heterozygous carrier. And therefore, this individual has both these variants and is homozygous for the 2 variants, whereas this child is compound heterozygous. And the siblings of this individual here, there's a 50% chance that every sibling will harbor this variant and be a carrier, and a 50% chance that every sibling may not have this variant and not be a carrier. So ideally, we say that HPLC hemoglobin A2 should be done for all siblings of carrier individuals, and if they are carriers, then the targeted mutation that is present in the family can be tested in them. Usually, these variants in the family remain the same, they don't change. We come to our next case, which is Duchenne muscular dystrophy. In this, we know that it's an X-linked disorder. It affects 1 in 3,500 boys. It's a clinical diagnosis where symptoms start usually around 2 to 3 years of age, with progressively difficulty in standing up from the squatting position, climbing stairs. So there's the typical proximal muscle weakness, pelvic more than shoulder, and that gets affected later. And we know that this is the Valley sign, which was published by Dr. Pradhan from SGPGI, which is very useful clinical clue to diagnosis much before even the calf hypertrophy becomes prominent. And we know that all these features can also be a part of Duchenne muscular dystrophy. Now, it's a clinical diagnosis. There is no difficulty. Today is not the era where we do muscle biopsy to confirm the diagnosis. And it's very important to confirm the mutation because that not only confirms the disease, But also today, in the era of targeted therapies, the nature of the mutation is important. Beyond that, it is prevention, prenatal diagnosis, and carrier detection in other at-risk members of the family. Now, unlike the hemoglobin gene, which I showed you had only 3 exons, the DMD gene is the largest gene in the body. It has 79 exons or 79 coding parts, and you can see that they are labeled here. But luckily, we also have background information that 65 to 80% of patients will have parts of the gene missing or duplicated. And in 20 to 30%, we can have point changes in the gene. It's important to understand which exons are deleted or duplicated, because that not only gives us information of how severe the disease phenotype could be, it also is important today for therapeutic interventions. And this is just a sort of a cartoon that shows that sometimes you can have deletions like this, where if an exon is deleted, the preceding and the subsequent exon fit into each other, so it remains in frame, and some amount of the protein which is functional is formed. However, if it is out of frame, then there is, like here, if it is out of frame, then there is no protein that is formed, and it is a severe phenotype. You could also have point changes like a nonsense mutation or a missense mutation in the gene. Now, because we know that the predominant kind of mutation is deletion and duplication, so we use a technique which is MLPA to identify deletions or duplications in the gene as the step 1 test for a clinical diagnosis of DMD. Today, there is really no role of doing a muscle biopsy at the outset. 20 years ago, we used to do that because MLPA was not available. We were only able to test a few deletions and duplications. However, if there is no deletion or duplication, then we can go on to sequencing the disease gene. And this is just to show you what is the importance of knowing the exact kind of deletion or duplication, because today all the therapies are based on that. Secondly, it is very important for targeted testing of at-risk individuals for their carrier status, because we want to prevent situations like this where there are multiple affected members in the same family. And thirdly, to offer prenatal diagnosis in the family who's a carrier. So MLPA for deletions and duplications is also used for other tests like spinal muscular atrophy, where 100% of patients have at least predominantly have both copies of exon 7 of the gene deleted. In a small percentage, it could be 1 copy and a point change, but I think generally it's good enough to understand that whenever we have a clinical diagnosis of SMA, we need to do deletion duplication analysis. And then there are other disorders like hereditary motor sensory neuropathies and congenital adrenal hyperplasia. Everything is not only sequence-based. We have metabolite and enzyme testing. For example, this child born to consanguineous parents had seizure onset at 3 months of age. They were tonic-clonic seizures, not responding to phenytoin. A little deeper evaluation showed that the mundan had been done because this was a Muslim family. They did an early mundan. And after that, there was no growth of the child's hair. And there was also a little bit of rash. And so, keeping all this in mind, a clinical diagnosis of biotinidase deficiency can be entertained. A tandem mass spectrometry, which looks for acyl carnitines and various amino acid metabolites in a blood sample, gives a suspicion that it could be biotinidase deficiency, and a simple enzyme test with a turnaround time of 48 hours can be done to confirm the diagnosis and initiate treatment in the child. So, for metabolic disorders, this basic GLAC is a very, very important bedside test that needs to be done, which can give a suspicion of these metabolic disorders. And I'm sure there'll be another talk on this, so I'm not going to go into these details. But wherever we suspect a metabolic disorder, we need to do the urine ketones reducing substances, the urine GCMS analysis, which looks at organic acids, tandem mass spectrometry, the plasma amino acids, and then resort to molecular testing, because all the above will come back to you in about 3 days. Another group within the within the biochemical testing disorders is a family like this, where you have two twins. They are identical. They were well till 1 year, and then they started regressing, had seizures and a very severe neurological phenotype. The MRI gives you a clinical diagnosis of metachromatic leukodystrophy because of the tigroid pattern of white matter involvement. So we know that we can do an enzyme test, again with a turnaround time of 48 hours, where we can look at the aryl sulfatase A enzyme, because the gene makes this enzyme, and this can be tested in the lab. This is low, then go forward and confirm the diagnosis by molecular testing. The enzyme testing also becomes very relevant in situations where we get a variant of uncertain significance, and it acts like a surrogate functional marker to confirm the diagnosis and upgrade that variant of uncertain significance to at least likely pathogenic. Now, once we have done this entire exercise for one child, we can just do the targeted mutation testing to confirm that the other twin also has the same disorder. Now, in this pedigree, there are two boys, V and K, who could not complete school and they have behavior concerns. So, two boys affected. And in this pedigree, again, we have two boys who are affected with intellectual disability, and there is a history in all these stars of early menopause. With this sort of an X-linked pattern of inheritance, we would like to first think of Fragile X syndrome, which is the commonest inherited X-linked cause of mental retardation. And this is a typical presentation of developmental delay and behavior abnormalities. And we are taught in our clinics that every male with a normal head size, with intellectual disability, with or without a family history, we should test for Fragile X syndrome, which is a trinucleotide repeat disorder. So once by the bedside you have reached to this conclusion, the test that we need to do is very specific, because this is not a missense or a nonsense sort of a gene change that we previously alluded to. This is a triplet repeat disorder. You can see that in the initial part of the gene, which we call the 5' untranslated region, there are CGG repeats. Now, these are normally present in every individual, but we know that less than 45 repeats is normal, and more than 200 repeats causes disease, and in between is a pre-mutation, which is akin to a carrier status. And the test to identify the more than 200 repeats is the TP-PCR. This cannot be identified by Sanger sequencing or exome sequencing or metabolite testing. So this is the typical curve for an affected individual, and this is the typical pattern of a normal male individual. Then we come to the next generation sequencing. So this is the tool that is now, I think, accessible to everybody. It is where the 20,000 genes or whatever, how many ever genes we want, can be tested simultaneously. We may not have a specific diagnosis, but we think it's genetic and we can order an exome sequencing. However, it's not as simple as that. And that's what I'm going to show you in my next few slides. So we use a clinical exome. We know all the morbid genes. Those are the disease-causing genes. Either we can test the limited genes, or we can test all the 20,000 genes in a platform, or we can test the whole genome. It's like an apple is the whole genome, and the exome is just a slice of the apple. And that's currently what is used in clinical testing, because we know that 85% of the disease-causing variants will be identified within this exome. So it's good to start off with that. Now, taking a cohort of children who are floppy, either neonates, infant, or children, we know that the differential diagnosis can be very vast, as you can see from this slide. There is a few hundred genetic disorders that can cause neonatal hypotonia. I'm not even alluding to the non-genetic disorders that are responsible for this phenotype. But we also know that 50% of patients are diagnosed by history and clinical examination. And this sort of clinical phenotype detailing is absolutely a must to apply the appropriate genetic test. And if we do it in that specific order and manner, more than 90% of hypotonic children can be identified. So this is the overall how we do it by the bedside: central causes, peripheral causes, the various differential diagnoses. And I'm just going to take this one group, which is the congenital muscular dystrophy, which comes in a peripheral muscle cause, because this in itself is another huge cohort where children have this non-specific presentation of muscle weakness and usually an intellect that can be absolutely normal, or it could be delayed. So let us take this family with two affected boys. There were no antenatal fetal movements. There was polyhydramnios, again alluding to a neuromuscular phenotype. The children had normal cognition. They had predominantly motor delay with hypotonia, areflexia, and limited anti-gravity movements. And when an MRI was done for these children, there was extensive periventricular white matter dysmyelination, which is actually at variance with the clinical phenotype of a normal cognition. But this is a typical phenotype. So this was the MRI picture of congenital muscular dystrophy that occurs because of a LAMA2 mutation. So here we have extensive white matter changes with a normal or a near normal cognition. So these are the clues. We know what we are looking at, but still there are so many other genes within the congenital muscular dystrophy cohort. So here we can resort to exome sequencing to sequence the large number of genes together and arrive at our diagnosis of a compound heterozygous variant in the LAMA2 gene that causes the myrosin deficient congenital muscular dystrophy phenotype. Both are pathogenic variants, and this is an autosomal recessive phenotype, and we know that both children would be affected. In the days gone by, we used to do muscle biopsy or skin testing and stain it with myrosin to see that this myrosin is absent. However, today, because of the availability of molecular testing, we don't need to resort to this as a primary test. Sometimes, if there is a variant of uncertain significance, then this can again serve as a functional test to confirm that that variant is actually disease-causing. In another scenario, again, two children with hypotonia and all the things that go along with hypotonia. Accidental death at 2 years for the first child, but the same happened for the second child. So the second child was extensively evaluated, but a diagnosis was not confirmed. And while walking down the stairs, again, this child had a sudden death. Now, when we put 2 and 2 together, a sudden death, it cannot happen by chance in 2 affected children. So then you would think that is there a rhythm disorder, a cardiac rhythm disorder that is causing this phenotype? And so we have hypotonia with a suspected cardiac rhythm disorder, but we don't know what gene to look at. There is no sort of clinical clue that will lead us to a specific gene. So are we going to do Sanger sequencing? No. Panel testing? No, because we don't know which panel of genes to look at. And so we do exome sequencing and identify a variant in a gene that causes CPVT. It's a rhythm disorder. And patients with this CPVT type 5 could have associated hypotonia. So this puts the entire clinical picture and the variant, it gives us a specific diagnosis. But there are also perils of exome sequencing. And you can see here, this child was born to consanguineous parents and is dysmorphic. And when the testing was sent, the exome sequencing, the phenotype that was provided was there was an anti-mongoloid slant, proptosis, low set ears, depressed nasal bridge. And all this phenotype is very, very non-specific. So nothing was identified. A variant of uncertain significance was present in the AHDC1 gene, which was not consistent with the phenotype of the child. Now, when the child was examined in detail, we realized that this child had a cloverleaf skull and there was craniosynostosis. There was a broad thumb and toe, and there was limited extension at the elbow. And a CT scan with the bone window confirmed that there was not only increased pressures inside, but all the sutures were fused. So now you do an OMIM search because you may not know what you're dealing with. If you put in the non-specific phenotype of anti-mongoloid slant, proptosis, low set ears, you will really get a host of disorders. You can see that there are 26,000 entries. However, if you put in key features which are uncommon, like either a cloverleaf skull or craniosynostosis, proptosis and broad thumb, you get only 3 entries. Now, armed and of which there are 2 diseases, Pfeiffer syndrome or another disorder here, which is a neurodevelopmental disorder. Armed with this knowledge, you go back to the first exome that was done and look at it. This is your diagnosis lying here, confirming the diagnosis of Pfeiffer syndrome in this child. So the test will not speak unless we speak to the test. And I think that is a very, very important message that we need to give. And just before I conclude, just bringing in within this phenotype of hypotonia, just to explain to everybody what cannot be identified on exome sequencing. This is Prader-Willi syndrome. Again, a clinical diagnosis by the bedside in the neonatal period in the first year of life, because this is a phenotype that evolves. We need a methylation analysis and MS-MLPA because this is a genomic imprinting and a methylation disorder. And this is how the test is done. So if you suspect Prader-Willi, the test to be sent is methylation testing. Spinal muscular atrophy, I've already spoken about, and MLPA is done for SMA. And here we have another differential within the group of hypotonia, which is congenital myotonic dystrophy, which again is a clinical diagnosis because you can elicit the myotonia. Now, this is again a triplet, a trinucleotide or a triplet repeat disorder. So the test that is done is TP-PCR. Okay, so this is showing the expansion in the TP-PCR, just like Fragile X syndrome. So whilst the genomic technologies are many to diagnose not only chromosomal disorders, but also monogenic disorders, the tools have rapidly evolved, as you can see here. The depth of sequencing and the depth of being able to pick up genetic changes is becoming much more and more. It's very important that the phenotype, we have to start with evaluation of the family history and the affected child, which is an absolutely inexpensive tool. Understand what are the groups of disorders, a thorough clinical evaluation to come to a clinical diagnosis, and then order the appropriate genetic test. Wherever there are some difficult features, different phenotypes, a behavior pattern which is not clear, it's really relevant to seek opinion from a geneticist, because the disorder is only confirmed if we do an appropriate test. There is no one blanket test for all genetic disorders. And I think, like in all specialities, even in genetics, the eye does not see what the mind doesn't know. And therefore, this is the real importance of this series that has been put forward by IAP Telangana. And I think our motto should be knowledge, an eagle eye, clinical examinations, listing out the differentials, and then ordering the appropriate test. So I conclude there.
Thank you.
Thank you very much. And please let me know if there are any questions.
Excellent
Thank you,
presentation.
ma'am, for that wonderful presentation, highlighting all the important aspects of monogenic disorders and the various types of variations that you can see, and all the different testing that needs, the different types of tests that need to be done in the different clinical scenarios. And those were excellent illustrative clinical scenarios. Thank you so much, ma'am. I think we can take up the questions, sir.
Yeah.
Yeah.
Sir, two questions are there. And Dr. Vikas Khatewa, in case of reported variant of labeled as VUS, but the phenotype is matching with the variant very well, how to proceed in such cases? And what makes certain genes to mutate? These are the two questions, sir. And Prajna madam or Ratna madam, please, you can answer.
Ma'am, Shraddha ma'am, would you like to?
Yeah. So
ahead?
actually, this variant of uncertain significance is, we get it very commonly in our reports. And actually, it needs a lot of depth beyond just doing a phenotypic match. And I'll explain to you why. Most of our phenotypes are common, supposing we take global developmental delay and seizures. So that could be a part of so many syndromes. So when we say that there is a phenotypic match, either we have done something, say, like an enzyme test, if there is one for that specific disorder, or we have done another semi-functional sort of a test if we are seeing craniosynostosis, and we've done a CT bone window to confirm the craniosynostosis. But without all that, just saying that it matches the phenotype and therefore I think that this is the disorder, I think that we should not do that. Let the VUS remain as a VUS. And if you strongly think as a doctor, as a primary doctor, that, well, this is what I think that the disease is, it becomes relevant to speak to the geneticist, because there are various other tools that we can use to understand whether that VUS can be upgraded or downgraded. Pragna, would you like to add to that?
I think you very comprehensively covered that, ma'am, and also in your case scenarios, you have touched upon these aspects. So you can look for further corroboration, as madam had pointed out, with additional laboratory evidence, additional imaging evidence. In some cases, for example, for a congenital myopathy, if you get a VUS, you can do the muscle biopsy, look for the histopathological evidence. But beyond a point, for many of these variants, there's nothing much you can do, and you just need to keep them under follow-up. And you keep reviewing them every 6 months. You keep reviewing the status of the variant in the databases every 6 months. And what happens is sometimes evidence builds up over a period of time. So so what's being classified as a variant of uncertain significance today, maybe 1 year down the line, with more robust evidence in the databases, with possibly functional studies which might have been done in the interim, possibly reports from other centers in the interim, the status of the variant may get reclassified as sometimes likely benign or benign, sometimes as likely pathogenic or pathogenic. So you can do some of these corroboratory things, but beyond that, you have to keep them under follow-up and keep reviewing the status.
Yeah. Ma'am, second question is from Dr. A. Tilak. What makes certain genes to mutate?
Yeah. Pragna, you'd like to take that?
Okay, ma'am. So basically, these variants or mutations a lot of them actually happen as errors of replication. And many of them, of course, may be passed down through several generations. And especially for autosomal recessive disorders, you would be having the parents and the parents' parents and so on being carriers for that. And it never comes to light because carriers are asymptomatic, most of them. But then in one individual, when the variants come in a biallelic form, both alleles get affected. That's when the phenotype manifests. And then you come to know that this particular autosomal recessive disorder exists in the family. So many of these variants can get transmitted in a asymptomatic carrier status form through generations. But the reason why mutations happen as they do in the first place, so a lot of them happen as errors of replication, because when DNA replication happens, a lot of these errors do occur, but most of them are corrected. So there are some DNA polymerases and all which are like, they correct these errors, and most of them are then corrected and they do not get retained. But sometimes these errors do not get corrected, they are retained, and then when these variants are present in important coding portions of genes, or important regions of the genes which can alter splicing and so on, that's when they end up being disease causing. There are external mutagens as well, including radiation and certain chemical agents and things like that. But many of these external mutagens are actually responsible for somatic acquired mutations, whereas most of these inherited germline mutations are more often due to errors of replication. Ma'am, would you like to add to that?
Yeah. So there are also some repeat regions, very similar regions in our genome. And so when they come together, as Pragnya said, the errors of replications are more prone there. We have many genes, we have many pseudogenes, and the pseudogenes are very much like the main gene, except for a couple of changes here and there. And so when they come together during meiosis, errors can happen there. And that's one of the commonest reasons for alpha thalassemia, because there we have 4 copies of the genes, as well as there are other pseudogenes there.
Yeah, thank you, ma'am. And one doctor has asked to share the slides. What I am saying to the Dr. Bhaskar Reddy Garu, it is available in YouTube. You can, at any free time, you can watch, all the doctors can watch your, open the YouTube, and if you are not a subscriber for the IAP TCP channel or PATS channel, please subscribe yourself and you can get in the YouTube, sir. Any 1 year or 2 years or after also, you can go through this YouTube slides. So anyone in the RSV Sri Krishna, please request the
Why Dr. Ratna madam's picture is always blurred?
For some reason, the light in the room has just gone, and I didn't, want to interrupt my presentation.
No, we could see you
What
clearly.
worried me was that is the internet going to go? So maybe some fuse has gone because the internet was working. It happened in the middle of the presentation, so I'm sorry for that. I didn't want to interrupt my presentation to correct that.
We would have been
Not
more
at all,
happier to
ma'am. Ma'am,
see.
you were very, very clearly audible, ma'am. So, and your slides were very
Yeah.
clearly visible. Yeah.
Thank you.
But we would have been more happier to see charming
I know,
personality.
but I don't know what's happened. So until I get up from this table, I'll never know what happened to the light in the room.
Yeah, thank you, ma'am. Excellent presentation.
RSV, please take over and request any other doubts from the other doctors, please.
Yeah. So this is the second episode, and just like you have a web series where you finish season 1 and you look forward to season 2. So this was season 2. I'm already looking forward to season 3. And on behalf of the organizers, I can tell you each season will be better than the previous season. And all credit to the team. Genetics, the topic itself, it's like a mystery. So each season is like a mystery thriller. And we are discovering new facets of medicine. And these are all aspects which are very exciting for practitioners. Day in and day out, you see so much of the routine that sometimes you want this difference in your life. And I'm sure all of you who have joined on Zoom, please come back to this episode on YouTube. And we are having a very good repository of past sessions as well. Apart from this, there's another of the presidential action plan, and this is a promise from our end to have pearls of wisdom from practitioners with decades of successful practice, treating hundreds and hundreds of patients across the state who are sharing their wisdom every Sunday. So today's PATS Pearls is by Dr. J. Daivadinam. He's a very senior practitioner from Nalgonda, and he has some pearls on acute gastroenteritis. I'll just show this for a couple of minutes and then propose the vote of thanks. So I'll just share the screen. One second.
Last episode was really interesting, but this presentation is more interesting and very lucid, clearly understood what message you want to tell to the general pediatricians. Thank you, Dr. Ratna ma'am and Dr. Krishna. We'll wait until our dynamic secretary says what are thanks. Now you are clearly visible, ma'am.
Because I've opened some light. Yeah.
Just 1 minute, I'm just opening that. Once I open it, I can then share screen. Yeah, here is the PATS Pearls for this week.
Not able to see.
Yeah, now you should be able to see it. Yes. So this is the PATS Pearls, and this is a presidential action plan where we have practical points in pediatric practice. And these are pearls on acute diarrhea. We know that acute watery diarrhea is a change in consistency of stool and or increase in frequency to 3 or more in 24 hours, and this need not always have fever or vomiting. And please continue to breastfeed the child, and babies who are on breastfeed sometimes pass loose pasty stools, which is not diarrhea. The mainstay of treatment is ORS and zinc. Please do not forget to write zinc in the management of diarrhea. It helps in reducing the duration severity of diarrhea. Probiotics, specifically only three mentioned: Lactobacillus rhamnosus GG, Saccharomyces boulardii, and L. reuteri DSM. These are adjunct to ORS and zinc. As important as treatment are preventive measures. So these are pearls of wisdom passed on by Dr. Daivadinam, and thank you, sir, for sharing your wisdom. And now coming back to today's wonderful session. Thank you, ma'am. And thank you all the experts. And we're very privileged that we have, apart from a talk, expert comments and insights from the experts in genetics who are sharing this from across the country. Thank you, all of you, for joining in. Thank you, all the listeners, all the people who have shared their queries and questions. It motivates the entire team. 450 views for the last episode. This motivates the team to continue to do more interesting webinars. And all thanks to the leadership of Dr. Bhaskar sir, the dynamic secretary, Dr. Sridhar, and of course, the entire executive board. Thank you all very much. I'll hand over to Dr. Bhaskar sir if he has any remarks at this stage.
I do not want to take your precious time. I have nothing more to say, but my special thanks to our Dr. Prajna Ranganath, the backbone of this entire webinar series, and very charming Madam Dr. Ratna Puri for lucid presentation. We could really, it was a case-based discussion, made it more interesting. I thank my team, all the listeners. Please do join again next month, first Sunday. Please encourage us and let's go ahead in serving our sick children in a better fashion. So thank you, Anandal, and namaskars.
Thank you, everyone. Yeah, so I'll be stopping the live stream now.
Thank you.
సార్ ఎండ్ ఆల్ కొట్టమంటారా సార్